Hello everybody, and welcome to the chapter on the human body, which will also be termed as anatomy. So anatomy refers to a structure and the components of a human body, the gross anatomy being what's visible to the naked eye, what you see every day. Microscopic anatomy is visible through a microscope, and so that might be the anatomy of a human cell or some of the other very small parts of the body. Physiology is defined as examining body functions, right? And so that could be something as simple as the respiratory system, the cardiovascular system, or even the integumentary system, right? Which is the function of the skin. The pathophysiology studies the functions of the body in an abnormal state, which would be something like cancer or diabetes or hypertension. Topographic anatomy refers to superficial landmarks on the body. And we're going to get into that a little bit more in depth here in just a little bit. But this is really in how you want to address a person when you're writing your chart and how you've assessed them, right? So the body in anatomical position is a very fixed position with palms turned out. We'll have a diagram and an illustration later to show you. So they're facing you, arms at sides, palms forward, and then that's the starting point of all anatomical reference. This is pretty much standardized so that when somebody is talking about a specific position that the body is in, everybody understands it. If you guys go back into your medical terminology, the exclusionary language is applied in anatomy almost every day. Most of your anatomical positions and other references are going to have some kind of Greek or Latin based root word to them. So make sure that you've kind of brushed up on that and practice some of these terminologies and understand the actual language used. When you're discussing the human body or your patient, you always want to make sure that you're referencing their left or their right. If you just choose left or right and you're not being very specific, that could be misinterpreted as you're looking at that patient on your left side of your field of view. That would be their right hand. So always try to make sure that when you're referencing somebody that you're using their anatomical position and their left or right hand. So if you look in this particular diagram or illustration, this is the three planes that we use for division of the body. This isn't really my favorite view. It's a little complex to kind of look at this particular one. So we'll get into a couple of different other illustrations that might make it a little bit more clear. But your three main axes are the coronal plane, the transverse plane, and the sagittal plane. And you can say mid-sagittal, and that's going to kind of get a little bit more in depth here in just a second. So if we're looking at these particular pictures, you can see anatomical position as the male figure, sans skin with palms out, right? So as you're facing that patient, that is forward facing with their palms facing your point of view. If you look on the picture on the left, this is a little bit more clear. And so a couple of the things that you want to remember is the sagittal plane is dividing the body from left to right with a perfectly vertical slice right down the middle. And then when we get to the coronal plane, that is dividing the body from front to back, and that's coming from left to right or right to left, however you want to see that. The other term for coronal plane is going to be the forward plane. That's often used in exercise physiology. The transverse plane is dissecting the body through the midsection of the torso in, again, the halfway position, and that's a horizontal slice. So we want to make sure that we understand our directions. Directional terms are pretty important when we're trying to eloquently describe what we've assessed and where an injury or a deformity might be, or some other thing that you're trying to describe in regards to your patients, right? So when we're looking at that, superior obviously is going to be nearer the head or above. We're always looking for something to go superior, inferior, and then proximal versus distal. Proximal is closer to the trunk or where the origin of that particular limb starts, right? So the upper arm is going to be proximal to the forearm or the distal arm right at the wrist. And you're always going to pair these, and you're going to use left or right, and we're going to describe how pain moves throughout the body using these particular terms. So we can also get into the smaller things with where we're at in midline versus to the outside edge of the body, and that's medial to lateral. Medial being that sagittal plane again. So this is pretty self-explanatory. Right and left, superior and inferior, lateral, medial, proximal and distal, superficial and deep, anterior or posterior. And if you look at the root words on that, you have ventral and dorsal, right? So everybody's heard of a dorsal fin, which would be on the back. And ventral, you would think about fish or sharks or something like that, where they have a vent, which is on the belly. Palmar and plantar, which is palms and the soles of the feet. And apex, meaning the point or the sharp defined section of a curve. When we're talking about movement, we want to talk about range of motion, which is the full distance a joint can be moved in a normal joint, right? So some people tend to be hyper flexible, and some people have limited mobility. So we're generally using this as a average for an average anatomically correct human being. Flexion is going to bring something towards the body, and extension obviously is going to push it away from the body. This also turns into abduction and adduction. Abduction meaning that it moves the extremity away from midline, right? We're taking away the abduction. Adduction, the core of that word being add, is going to bring something in towards the core. So if somebody is unable to move their, say, forearm away from the body, right? Now we have a problem with abduction. If they're holding it towards the torso, then it is adducted. And if they can only rotate a limb or a joint in those positions, that's how you would notate that. So back to normals for human beings, right? If they have hyperflexion, they're able to flex beyond a normal range of motion. And some people just have that ability. They have very long tendons and ligaments that allow a very deep stretch, and they're able to actually get a much higher range of motion than a typical person. Hyperextension means that that joint is actually now extended beyond what it's anatomically considered normal, and that's more the bones being more misaligned than the actual ability to move something in that range of motion. Supination is basically derived from the word supine, which is going to be facing upwards, right? So if you have somebody laying on the ground and they're in a supine position, they're going to be face up on the ground. And in turn, pronation comes from the word prone, which is going to be face down or belly down to the ground. Internal rotation and external rotation, pretty self-explanatory. Bilateral, meaning both. So that's going to be your left and right, right? So if we have somebody who we'll say has bilateral fractures to the forearms, that would be both arms, left and right. Or bilateral eye injuries, that would be left and right. Unilateral, meaning one side. So if somebody has a unilateral deformity to the upper extremity, that person is going to have one either on the left or the right, but it's not going to affect both. So anatomical positions. Again, we're talking about prone and supine, which would be face down or face up in a lying position. The Trendelenburg position is otherwise known as the shock position, and that's having somebody lay supine and then having their feet elevated above the torso. And it's often noted to actually have an increase in blood pressure when somebody's in shock. The Fowler's position is sitting with the knees bent. This is very typical of how somebody's going to be transported in a position of comfort on a gurney. Often we will say that they are transported in a semi-Fowler's if their legs are flat and they're still sitting up. The recovery position is going to be lying on a side with the lower arm being the extremity that they're resting their head against. Often we'll have the opposing hand come around and just sit underneath the chin and one leg in a bent position, kind of tripoding them. We see this very often in any of the CPR training anymore. Okay, the skeletal system and its anatomy. So as most of you guys are aware, the skeleton is what gives us our recognizable form. Most animals that have any kind of skeletal system, be it exoskeleton or not, are going to be conformed to the shape of the rigid bones or other structures in the body. The bones are held together with muscles, tendons, ligaments, and so when we're talking about this, we have tendons that are connecting muscles to bones, and the ligaments are connecting bone to bone. And so that's important for you to remember, is that a muscle to a bone is a tendon and a bone to bone is a ligament. Good ways to think about this is the Achilles tendon is attaching the calf to the heel, and the knee quite often has plenty of ligaments, right? The ACL, MCL, and LCL for ligaments connecting the upper leg to the lower leg, stabilizing the knee. The quadriceps coming across the kneecap on the patellar tendon is muscle to bone again. Cartilage is going to sit as a covering on the ends of bones, and it allows some of the bones to kind of move against each other freely with the help of synovial fluid. So we have several different types of bones, those being long bones, which would include the femur, the tibia, the fibula, the ulna, the radius, and the humerus, right? And so that's our long bones of the arm and the leg. Short bones would be the small cubical looking bones in the wrist and then the ankle. And then we have flat bones. So some of those are skull bones, ribs, and the sternum are considered flat bones. Here's a pretty good picture that shows the cross-section of a long bone, this one in particular being the humerus. And you can see where the marrow is stored, where it's produced, and where some of this bone becomes very dense. And as you look down in the lower portion of the cross section, you can see that there's actual vessels in there. And this is where our IOs come into play. Because red blood cells are produced in the bone marrow, we are often tapping into that vascular system to deliver fluid if we need be. So joints occur wherever two bones come into contact. It's the ends of bones again, right? And there's connective and supporting tissue. And we have several types of joints, right? So we have ball and socket joints, and then we have hinge joints. And most of these you can see. If we have a great need for articulation, it's going to be a ball and socket joint, which is going to be the shoulder, which is one of the more complex and most robust in terms of range of motion. And then we have hinge joints, right? So this would be your fingers and your elbow or your knee, where it's only supposed to kind of rotate in one plane, and we don't want any of the extra mobility because it would take away from the structural stability. The axial skeleton, if you think about this, the axis of the human body, if you just draw a line straight through the skull and down the spine, that is going to be your axial skeleton. So we're talking about the skull, the face, the thoracic cage, and the vertebrae, which is, again, the spine all the way down to the coccyx. So our skull has 28 bones and 3 different anatomical groups. The auditory ossicles, right? And that's 6 bones that function in hearing. The cranium has 8 bones that encase and protect the brain. That's its sole goal at that point. And then the face has 14 bones that protect the eyes, the nose, and the tongue. If you are aware of what a typical skull picture looks like, or a drawing, right? When they tend to have that jagged line all over them. Those are the sutures. We typically say that they're fused, but as we're growing up from small children, those are open. That's the soft spot in a child. This is another really good illustration. You guys can take a look at this and see how these are broken up into specific groups. And you can see where all of these bones get really small. And if you're looking pretty deeply into the eye sockets, you can see that there are several different bones actually in the eye socket that are creating that pocket for the eye to sit inside the cranial cavities. And now we're looking at just a picture of the bone, and this is more the base of the skull, and you can see the occipital bone and where the temporal and the frontal bones are. So this is kind of a top view of you looking down at the skull if it was to be kind of taken across from the top, and you can see where the brain is sitting in its pan. So facial bones is the maxilla, the mandible, and the zygomas, and that's obviously the upper lower jaw and the cheekbones, and all of these can be separated from the rest of the face. The orbit encloses and protects the eyes. It contains the eyeball, the muscles, blood vessels, nerves, and fat. A blowout fracture is a blow to the eye that might actually take the floor out of the orbit and allow the eye to move. And often when we see something like that, that's where an eye might be displaced. And we can get blood and fat leaking into the interior structures of the sinuses and the nasal cavity. Nasal septum separates the nostrils. For the most part, that's mostly cartilage. And anybody that's had like a septoplasty done because of a deviated septum or anything like that, the particular structure is cut out and reformed, and then have the cartilage sewn back into the flap of skin. The paranasal sinus contents drain into the nasal cavity, and that's going to be the small sinus pockets that are around the eyes and inside the nasal cavities that allow the mucus production to drain into the main nasal chamber. Sinusitis is inflammation of those sinuses, and that's where we get that telltale sign of like cranial pressure, headaches, and where the mucus production is coming from. The mandible is made of the lower jaw and the teeth, and then the temporomandibular joint allows movement of the mandible. So we're looking along the sides of the jaw up towards the ear, and the hyoid bone floats in the superior aspect of the neck just below the mandible, right? And so that's sitting really, really, really deep into the neck, kind of at the trachea, and it's its own small bone. The neck is 7 cervical vertebrae. It also encompasses the esophagus and trachea, which for lay people is the windpipe, right? And those lie midline in the neck. And on either side of the trachea, you have the jugular veins, the carotid arteries, and nerves. So if we're looking at this, this has got the sternocleidomastoid muscles, which is the long muscles in the front of the neck, you can see. And then if you look dead in the center there, you can see the thyroid cartilage. On men, we would call that the Adam's apple. And directly below that, you would see the cricothyroid membrane. This is the small pocket that paramedics are typically, if they're going to do what we call a cric, they're going to pierce a hole into that structure so that we can place a breathing tube there. Careful attention should be paid to where the carotid arteries are. You can see those are pretty deep, and that's one of the things that we struggle with when we're looking for a carotid pulse, is how to place your finger pressure on the neck so that you don't actually drag fat or tissue over the carotid, because typically, if we're looking for that carotid pulse, somebody has a very weak pulse, and it's already really hard for us to kind of find anything distal of the neck. So the vertebral column is composed of 33 bones. Each one of those is called a vertebra. The cervical spine is the first 7, the thoracic spine is 12, and the lumbar spine is 5. And so you can call that breakfast, lunch, and dinner if that kind of helps you remember, right? So the sacrum is 5 sacral vertebrae fused together, and that's across the rear of the pelvis. And the coccyx is the last 4 vertebrae, which are also fused together. And that puts that nice point at the very end of the pelvis in between the legs. If we're looking at the thorax, we're talking about the chest, and that's 12 thoracic vertebrae, and then 12 pairs of ribs. So that includes floating ribs or false ribs, and then also the sternum. So the anterior midline of the chest is the sternum, right? And that's the front, very center. It's a long, flat bone with a small crest. And then we have the bigger structures in the body, which is going to be the heart, the lungs, and the great vessels, right? And all of that is protected by the bony structure that's made by the thorax. So as we're looking at this picture on the left, you're going to see the jugular notch, which is sitting in the sternum, the manubrium, which is kind of where we have that transition or that crest on the sternum before it starts to take its new direction down the thorax, and then we get down to the middle of the sternum at the base, where you have the xiphoid process, which is another cartilaginous structure that's just at the very base of that and kind of sitting in between the ribs. Then we're looking at the anterior ribs, and you can see that there's all 12 ribs there, with the 11th and 12th being floating ribs. They don't actually connect back up into the sternum. And then if we look at the major structures that are protected by that, you can see we have the two lungs, the heart, the great vessels, which is going to be your superior vena cava, and then your aorta, right? Those are both going to, you'll have your aorta run down through the midline of the body with the inferior vena cava, and they are going to be protected by all of the tissue along the spine. Shoulder girdle attaches to the upper extremity of the body, the upper extremities, forearm, the wrist, and the hand. And then we have the pelvis, where the extremity attaches to the body, right? So we have like our legs come into the pelvis connecting to the spine, which is now connected to the thorax. Lower extremities are hips, thighs, knees, legs, ankle, foot, and toes.